Hello, my name is Mira Ghanem, and I'm an assistant professor of trauma and acute care surgery at R. Adams Cowley Shock Trauma, the University of Maryland Medical Center. I would like to start off by thanking EAST for selecting the Brain vs. Bone study as the winner of this year's Multicenter Trial Junior Investigator Award. Traumatic brain injury is a major healthcare-related problem in the United States, and TBI is most commonly associated with long bone fractures. Recently, it has been shown in animal models that long bone fractures in the setting of a TBI worsen early neurologic recovery and subsequent learning and memory. Early stabilization of long bone fractures is associated with favorable outcomes, and while some groups advocate immediate definitive fixation with intramedullary nailing or open reduction and internal fixation, others support the concept of damage-controlled orthopedics with temporary stabilization with external fixation. The optimal method and timing of long bone fracture fixation in the setting of TBI remains not very well understood. Given the risk of adverse neurologic sequelae in the setting of an associated long bone fracture, and in moving towards identifying treatment strategies in the TBI patient that improve outcomes, it becomes essential to establish a better understanding of the neurologic sequelae of the different fracture fixation modalities in the setting of TBI. The aims of the study are to determine whether the type of lower extremity fracture fixation modality influences cognitive outcome as it's represented by the Rancho-Los Amigos score at discharge GCS, and motor score as compared to the admission, GCS and motor score, and additionally whether timing of fracture fixation influences outcomes. This is a prospective observational study where patients who are greater than 18 years of age or older with a GCS motor score less than 6 within 24 hours of admission, a head AIS greater than 2, and an operative lower extremity fracture can be included. Those who are determined to be non-survivable on admission, prisoners, parolees, those on probation, and pregnant females are excluded. IRB approval per participating site is required. Decision and timing of operative intervention is based on the standard of care at the participating facility. The fracture fixation groups are divided into XFix, IM nail, and ORIF in the setting of mild to severe traumatic brain injury. Participating sites must utilize the Rancho-Los Amigos tool as the primary cognitive evaluation tool for traumatic brain injury patients. Data will be collected over an 18-month period and uploaded onto the AAST data collection tool. For any questions, please feel free to email me at brainversusbone@gmail.com, and I look forward to collaborating with you.
Hello, my name is Lindsay O'Meara. I am a nurse practitioner at the R. Adams Cowley Shock Trauma Center at the University of Maryland Medical Center. I would like to thank EAST and the Multicenter Trials Committee for the privilege to present the ACEs trial, Anticoagulation in Emergency General Surgery. Who bleeds more? It has been reported that the annual case rate in the EGS population is approximately 1,300 per 100,000 patients, with the elderly population representing 48% of that. With the increase in the prevalence of atherosclerotic disease in the elderly, there has been an increase in the use of antiplatelets and anticoagulants. Warfarin has historically been the anticoagulant of choice for the treatment of stroke, AFib, and DVT-PE. In recent years, the use of direct oral anticoagulants, or DOACs, have increased in popularity due to their rapid onset and offset, fewer drug interactions, and no need for routine drug monitoring of coagulation status. DOACs, however, unlike warfarin, continue to have a lack of reversal agents, mainly due to cost constraints and availability. Given the lack of data regarding bleeding progression and complications in the EGS patient population taking DOACs, we aimed to determine the bleeding risk and need for unplanned interventions secondary to hemorrhage or hematoma in EGS patients taking a DOAC versus warfarin plus or minus antiplatelets undergoing urgent or emergent surgery. We will also aim to evaluate the mortality rate between the two groups and evaluate the rate of post-thrombotic complications during the hospitalization. This will be a prospective observational study. Inclusion criteria will be all emergency general surgery patients confirmed to have taken a DOAC or warfarin with or without antiplatelet therapy within 24 hours of urgent or emergent surgery. The decision and time to operation will be the responsibility of the attending surgeon, therefore no protocols or guidelines will be used in order not to influence surgeon decision making. Prisoners, wards of the state, those who are pregnant and under the age of 18 will be excluded. Those who received their index operation at an outside hospital and were then transferred to your facility will also be excluded. All data points will be prospectively collected on a standardized form that will be provided to each participating institution. Data will then be entered into the Research Electronic Data Capture, commonly known as the REDCap portal. If you are interested in participating in the ACES trial or have any questions, please contact me at eastacestrial@gmail.com or lomira@umm.edu. Thank you.
My name is Sharvin Tagavi, and my co-investigator, Juan Duchesne, and I are from Tulane University School of Medicine in New Orleans, Louisiana. We will be conducting a multicenter trial examining pre-hospital procedures in penetrating trauma patients. The data is clear that pre-hospital procedures can be beneficial in traumatic brain injury or when transportation is prolonged, such as in rural settings. However, data is less convincing for penetrating trauma. In urban cities like Philadelphia and Boston, there is never a trauma center too far away from pre-hospital responders. Retrospective data suggests that in this setting, with penetrating injury in urban areas, transport to trauma centers should take precedence over procedures such as IV line placement and endotracheal intubation. In addition, with new ACLS guidelines prioritizing uninterrupted chest compressions over advanced airway, it is time to re-examine the role of advanced airway in trauma patients, along with other pre-hospital procedures. Despite these findings, pre-hospital procedures are still being carried out in the field in penetrating trauma patients in urban locations. The negative effects of pre-hospital procedures may be related to time and delay in surgical control of life-threatening bleed. However, both clinical and animal studies have shown that pre-hospital procedures can actually cause physiological changes that are harmful. For example, endotracheal intubation can exacerbate malperfusion of vital organs in severe hemorrhagic shock when bleeding is uncontrolled. The specific aims for this study are as follows. Number 1, to determine if penetrating trauma patients with pre-hospital procedures have a survival advantage over those without pre-hospital procedures. Number 2, to determine if penetrating trauma patients that have pre-hospital procedures have decreased morbidity. And finally, to determine if patients brought in by private vehicle or police transport have better survival than those brought in by medical transport crews, such as BLS or ALS crews. Our hypothesis is that for penetrating trauma patients in urban locations, those that do not receive pre-hospital procedures will have better outcomes than those that do receive pre-hospital procedures. The inclusion criteria for the study will be as follows. Patients with gunshot wounds and/or stab wounds to the torso and/or proximal extremity known to be age 18 or older. The torso will be defined as the area between the clavicles and above the inguinal ligaments, pubic symphysis, and gluteal folds. The proximal extremity will be defined as the extremity proximal to the elbows and/or knees. Number 2, patients with torso and/or proximal extremity penetrating injury combined with the distal extremity injuries. And finally, patients with penetrating torso and/or proximal extremity injury combined with a blunt injury. The exclusion criteria for the study will be as follows. any injury above the clavicle, including the head or any neck injury. Patients with traumatic brain injury will be excluded from the study. Patients with distal extremity injury only, so injury distal to the elbows or knees. 3, patients with isolated blunt mechanism of injury. 4, any transfers from outside institutions. And 5, patients age 17 or younger. Please contact us if you're interested in participating. We hope to talk to you soon.
Hello, I'm Rebecca Main. I'm a trauma and acute care surgeon at the University of North Carolina, Chapel Hill. Together with my colleagues, I am presenting our proposed multicenter trial to evaluate the surgical needs of incarcerated patients. This is a population whose surgical needs and outcomes have not been well described, and we are hoping that a multicenter trial will help define the epidemiology and challenges for this population so that strategies to improve care delivery and outcomes can be developed. As you may know, since the 1970s, due to a variety of public policies, the U.S. has led the world in both the number of incarcerated individuals and the rates of incarceration. Whereas 5% of the world's population lives in the U.S., 22% of the world's incarcerated population resides there. The U.S. incarceration rate is 5 times its nearest NATO neighbor. Currently, there are over 2.3 million incarcerated individuals who live in state and federal prisons and jails. This figure demonstrates the distribution of prisoners in the U.S. Prisoners are the only group with a constitutionally guaranteed right to basic health care. This right is based on a ruling that determined failure to provide basic health care constituted cruel and unusual punishment, which is illegal under the Eighth Amendment. The largest area of spending in the criminal justice system is healthcare. In 2015, $8.1 billion were spent by states on healthcare for prisoners. The investment in prisoner health varies significantly by state, but their average spending is around $5,000 per prisoner per year. While basic health care is guaranteed, incarcerated individuals still face several barriers to accessing health care. Co-pays are required in most states. Standardizing to prisoners' wages, which are often less than $1 per hour, to the federal minimum wage, an inmate's co-pay is frequently equivalent to hundreds of dollars per visit. While this is argued as a means of deterring inmates from frivolously seeking health care, it serves to limit and delay access to care for individuals who are sick. Furthermore, there are no clear standards about how health care should be delivered to incarcerated individuals, and different states have adopted varied models. Given the large number of incarcerated individuals in the United States, it is somewhat surprising that there is limited data available on their health needs and health outcomes. The existing data suggests that there are significant health disparities. One factor driving these disparities is the disproportionate incarceration of groups like minorities and lower socioeconomic individuals who have worse health outcomes in general. In addition, the number of inmates over the age of 50 is growing. By 2030, it is predicted that 1/3 of all incarcerated people will be over the age of 50. In some states, health care for this older incarcerated population constitutes the majority of health spending for the justice system. Many people, when they are incarcerated, already have more pre-existing conditions than the general population. This includes infectious diseases and chronic conditions like asthma, HIV, diabetes, and hypertension, as well as mental health conditions like drug abuse, depression, PTSD, and alcohol abuse. In addition, incarcerated individuals are more likely to have suffered a previous trauma. There are several reasons that the medical and surgical needs of prisoners are not yet well described. One challenge is identifying patients retrospectively. It is hard to use any particular proxy to identify prisoners from jail and from prisons because each state and federal facility manages their healthcare needs differently. Furthermore, national trauma registries like the National Trauma Data Bank or other large surgical registries like NSQIP, STS, and SEER do not include incarceration as a variable for the patients. While there are periodically surveys from the Bureau of Justice Statistics of the healthcare needs of inmates, these do not always report on surgical conditions. The survey from 2004, the latest to do so, noted that 12% of inmates in both state and federal facilities had undergone a surgical procedure while incarcerated. People over the age of 45 had much higher rates of surgical procedures. The report, however, did not describe what the surgeries were, whether they were emergent or elective, and what conditions they were treating. The available data suggests that there is a significant need for acute surgical care for incarcerated individuals, given that 1 out of 8 people will have a surgery while incarcerated and 1 out of 3 will be injured. Disturbingly, it appears that between 20 and 30% of prisoners are not evaluated by healthcare professionals after injury. Other data suggest this number may be even higher. A study of patients who died while in custody who had a acute surgical or traumatic condition as their cause of death found that only 33% of patients who died had undergone an operation before their death. Self-harm and suicide are significantly higher problems in the inmate population. Again, this is multifactorial. However, there is little evidence to direct surgeons how to appropriately treat self-harm activities among this population and to fully identify which patients who are participating in self-harm are at the highest risk of progressing from self-harm to suicide. The goal of our study is to identify incarcerated patients and assess their acute surgical needs across several sites. We propose a prospective design as we have found that it is quite difficult to reliably identify patients who present from both jail and prison via retrospective chart review. Our primary goal is to gain a better understanding of the epidemiology of the surgical delivery to incarcerated patients. Our secondary goal is to understand the outcomes of these patients after their surgical interventions. We will include all adult patients over the age of 17 who present from either jail or prison if they have an acute surgical condition and are evaluated by at least one surgical service. Patients who do not have a surgical diagnosis or who are not evaluated by a surgical team will be excluded. Participating institutions will collect basic patient information, clinical information, and outcomes. Included in this will be information about what type of facility the patient is presenting from and where they are discharged to. We will also include information on who the payer is. The goal of this analysis is to determine the prevalence of acute surgical conditions in the population of incarcerated patients who present to non-correctional facilities. We will include in the diagnoses indications of duration of disease and delays in presentations, like perforation of appendicitis. We hope this will guide future work to compare specific disparities and delays in reaching care for incarcerated individuals. One of the reasons that we have limited information about prisoner health is that prisoners are considered a protected class by the government and thus institutional review boards. This is because they are vulnerable to coercion and may be influenced to participate in studies, inappropriately believing it could affect their incarceration. But being a protected class does not mean that no research should be included on prisoners. In fact, we argue that it is specifically because they are vulnerable to injustice in research that makes this project to characterize their specific needs and outcomes important. While a retrospective study of incarcerated patients would be ideal, in our system, and we suspect in others, identifying whether a patient was incarcerated immediately prior to hospitalization is challenging. Recently, our IRB approved an initial study of the subgroup of incarcerated patients we could identify by payer, with a waiver of consent. However, this missed patients coming from jails and likely federal prisons. This is why we propose prospectively identifying patients in this trial. Our hope is that, based on the minimal risk to patients, the volume of patients to be seen, and the need to include patients seen, evaluated, and discharged in the emergency room, this study will also qualify for a waiver of consent. We are happy to help interested institutions with their IRB process.
A special thank you to EAST and the Multicenter Trials Committee for the opportunity to share with you our proposed study regarding subtotal cholecystectomy for complicated acute cholecystitis. My name is Zach Warner, and our primary investigator is Kazuhide Matsushima, both out of the LAC USC Medical Center in Los Angeles. Subtotal cholecystectomy provides a viable alternative to the difficult gallbladder. Despite its relative frequency when severe inflammation or unfavorable anatomy are encountered intraoperatively, few studies exist establishing this as a common and safe surgical practice. Additionally, different variations of this technique have been described, with little to no data comparing their effectiveness, safety, or effect on short and long-term patient outcomes. The primary aim of this study is to determine the safety and efficacy of subtotal cholecystectomy for treatment of complicated cholecystitis. Additionally, evaluation of the effect of fenestrating versus reconstituting subtypes will be carried out, further elucidating any significant difference the chosen technique has on patient outcomes. We plan to perform a multi-center prospective observational study including all adult patients with acute cholecystitis. Any patient with other biliary diagnosis or prior biliary intervention will be excluded. Data collection will be centralized through REDCap, obtaining information on patient demographics, preoperative indicators, disease severity, and chosen operative technique. Short and long-term outcomes will be collected for comparison to determine the safety and efficacy of subtotal cholecystectomy. These include iatrogenic injury, need for secondary intervention or completion cholecystectomy, recurrent biliary infection, and mortality. Long-term outcomes will be defined as those that occur beyond 6 months from operative intervention. In conclusion, we would like to invite you to join us in what we feel is an important multi-center trial that has the potential to greatly affect patient care. Please contact us with any questions or suggestions you have. Thank you.
Welcome. I'd like to thank EAST for the opportunity of presenting our 2019 EAST Multicenter Trial entitled Prospective Multicenter Derivation and Validation of a Necrotizing Soft Tissue Infection Score, Necrosis. My name is Dennis Kim. I'm a trauma surgeon at Harbor UCLA Medical Center in Torrance, California. NSTIs are associated with significant morbidity and mortality, and early diagnosis and operative intervention are critical for successful outcomes. One of the key issues with NSTIs is distinguishing them from other severe skin and soft tissue infections. To this end, a variety of scoring systems have been developed based on lab as well as radiographic criteria. The issue with these scoring systems is they lack sensitivity, have varying reproducibility, and oftentimes lack key clinical criteria. The objectives of this study are to develop and validate a clinical risk index score for identifying NSTIs in emergency general surgery patients being evaluated for severe skin and soft tissue infections. This is a prospective observational study. It will involve both a development and validation cohort, and we're looking at all adult patients referred to the Acute Care Surgery Service for evaluation of a SSTI. The main outcome measures include intraoperative clinical confirmation of an NSTI as well as 30-day mortality. We'll be looking at a number of different variables including patient demographics, clinical presentation, admission lab results, scoring systems, results of radiographic investigations were available, microbiologic results, as well as variables related to both medical and surgical therapy and outcomes. If you are potentially interested in participating in this multi-center study, please do contact me at the emails below.
Hi, I'm Kaushik Mukherjee from Loma Linda University, and my study is called Sleep Time for Sedation Level After Emergent XLAP Without Primary Fascial Closure, Time to Closure. Damage control laparotomy is the standard of care for many critically ill and injured patients after surgery. After DCL, it is important to rapidly achieve primary fascial closure to avoid further complications. Traditionally, this has been accomplished with deep sedation or neuromuscular blockade, but these interventions can result in delirium and physical deconditioning. The effects of sedation level on rates of PFC, delirium, and other outcomes have not been well studied. We seek to use a multicenter retrospective cohort to determine the confounder-adjusted effect of sedation level on time to PFC after damage control laparotomy for trauma and emergency surgery. We also seek to determine the confounder-adjusted effect of sedation level on surgical complications, delirium-free, coma-free ICU days, and ventilator-free ICU days. We hypothesize that light sedation is not inferior to deep sedation in terms of achieving primary fascial closure, and that light sedation is superior to deep sedation in terms of the proportion of coma and delirium-free ICU days. We hope to have a cohort of 310 patients to demonstrate non-inferiority with 90% power, but 400 patients would be ideal to maximize generalizability of the study. In our preliminary data, we showed that prescribing practices for deep sedation vary significantly with surgeon experience, and in a single center cohort, we demonstrated that shorter sedation exposure was not associated with prolonged time to primary fascial closure in a trauma population. Furthermore, we also demonstrated that longer sedation exposure was associated with a decrease in the proportion of coma-free, delirium-free days. Our study includes adult patients with an open abdomen after trauma or emergency surgery with daily recorded RAS and CAM-ICU scores, and will include patients from January 1st, 2017 through the end of 2018. We believe this is a novel research question which has implications for change in treatment of patients. It is already IRB approved, and we plan to use an easy REDCap-based data entry system. We plan for abstract submission to EAST by July 1, 2020. Thank you for listening, and we hope to have your participation.